Welcome back to the Explainer. Today we're taking on nephrolithiasis, or as it's better known, kidney stones. Now, if you've ever stared down a massive, overwhelming list of facts, crystal shapes, and treatment algorithms for this topic and just felt totally lost, you are absolutely in the right place. We're going to take that static textbook list and turn it into a compelling, highly logical medical mystery. By the end of this, you won't just understand the clinical presentation, you'll be ready to totally ace your exams. Let's get started.
All right, let's dive right in. Picture this classic board exam vignette. Read it, memorize it, internalize it. Patient suddenly develops severe unilateral flank pain that radiates to the groin with nausea and vomiting. This is it, the quintessential clinical encounter. The pain is sudden, it's severe, and it's colicky, meaning it comes in these excruciating waves because the ureter is literally spasming against the stone. And the nausea and vomiting? Well, that's just a direct result of the intense visceral pain.
So here's our game plan to master this topic. We're breaking it down into 5 clear steps. First, the classic clinical presentation. Second, the 5 stone types. Third, the high-yield diagnostic workup. Fourth, acute treatment and emergencies. And finally, procedures and future prevention.
Okay, Section 1, the classic clinical presentation in its classic symptoms. Let's talk about how this patient actually looks when they roll into the ER. Now, this is a massive board exam pearl right here, and it's all about the patient's physical behavior. A kidney stone patient is famously incredibly restless. They're writhing in pain, constantly shifting around, just completely unable to find a comfortable position. You've got to contrast this strongly with the patient who has peritonitis, saved from a ruptured appendix. That patient, they'll have guarding, rebound tenderness, and they will be lying completely still because even the slightest movement aggravates their inflamed peritoneum. So if the vignette describes a patient pacing the room or writhing on the gurney, you're almost certainly dealing with a stone.
And you know the exact spot they feel that pain? It's basically a real-time anatomical map of where the stone is currently lodged. If the stone is up in the kidney or the upper ureter, you get that classic flank pain. But as it travels down into the mid-ureter, the pain actually shifts to the lower abdomen. And finally, once it reaches the distal ureter, the pain radiates straight down to the groin, testicle, or labia. So the physical location of the stone directly dictates where that pain radiates.
Moving right along to Section 2, the 5 stone types and their crystal characteristics. We know the symptoms, so now let's figure out exactly what kind of stone is causing all this agony. Okay, if you need to, pause here and really internalize this, because this is without a doubt the most high-yield concept of the entire explainer. Kidney stones form when urine becomes supersaturated with specific substances, causing them to precipitate out as crystals. And we basically have 5 major types to worry about: calcium oxalate, calcium phosphate, uric acid, struvite, and cysteine. Let's quickly break down the most commonly tested features for each one.
So what's fascinating here is just how common calcium oxalate is. It's the most common kidney stone overall, hands down. On a urinalysis, it shows up as these distinct envelope or dumbbell-shaped crystals. So whenever you hear envelope shape, you need to instantly anchor that to calcium oxalate. These can form at literally any urine pH, and they're typically driven by hypercalciuria or even malabsorption conditions like Crohn's disease.
Next up, we have struvite, which is made of magnesium ammonium phosphate. These form these crazy coffin lid-shaped crystals in alkaline urine. The absolutely crucial association you need to make here is recurrent urinary tract infections caused by urease-positive bacteria, like Proteus. So, coffin lid crystal, alkaline urine, recurrent UTIs. That's your classic struvite triad.
Then there's uric acid stones. These guys form rhomboid-shaped crystals in highly acidic urine, and you'll often see them in patients with gout or high cell turnover. But watch out, here's a classic test maker trick. Unlike calcium or struvite stones, uric acid stones are completely radiolucent, meaning they are completely invisible on a standard plain KUB X-ray.
Finally, cysteine stones. This is a perfect example of how test makers reward visual associations. You can instantly diagnose the genetic condition cystinuria just by spotting a hexagonal crystal in a test question. Hexagonal equals cysteine every time. They form in acidic urine, and they're only faintly radioopaque.
Let's switch gears to Section 3, high-yield diagnostic workup. Now that we know what these stones look like under a microscope, how do we actually image and diagnose that patient who is currently screaming in the ER?
Well, the clinical workflow is super structured. Step 1 is always a urinalysis. Step 2, for almost all adults, is a non-contrast CT of the abdomen and pelvis. This is the absolute gold standard because it tells us the exact size, the location, and whether or not there's an obstruction. It even catches those sneaky, invisible uric acid stones we just talked about. However, step 3 is a really important exception. Ultrasound is your preferred, safe alternative if the patient is pregnant or if they're a child, simply because we want to avoid unnecessary radiation.
Zooming in on that initial urinalysis for a second, here's what you're really looking for. Microscopic hematuria is by far the most common initial lab finding, and when you think about it, that makes perfect sense, right? This hard, jagged little rock is literally scratching and abrading the urinary tract as it gets forced down the ureter. We also check the urine pH for clues. Remember, uric acid is acidic, struvite is alkaline. We hunt for those crystal shapes. And critically, we look for pyuria and bacteria because if we see those, we might be dealing with an infected stone, which changes everything.
Which brings us right into Section 4, Acute Treatment and Emergencies. First-line interventions. This is where your clinical judgment really gets put to the test, easing the pain and knowing exactly when to hit the panic button.
Here's something that often surprises people. First-line treatment for acute pain control? It's actually NSAIDs, like ketorolac or diclofenac, assuming there are no contraindications. You'd think we'd jump straight to heavy opioids for pain this bad, right? Actually, no. NSAIDs are vastly superior at first because they don't just mask the pain, they directly reduce the ureter spasm that's causing that intense colicky pain in the first place. You'll also want to correct any dehydration with IV fluids, though. Just as a heads up, routine aggressive hydration doesn't actually force the stone out any faster. Now you've got to pay very close attention here, because these are your absolute red flags for urgent urologic intervention. A stone plus a fever? That equals an infected obstructed kidney. That is a true urologic emergency requiring immediate decompression with a stent or a nephrostomy tube plus IV antibiotics. Other major red flags include sepsis, acute kidney injury, an obstruction in someone with only one functioning kidney, bilateral obstruction, pain and vomiting that you just cannot get under control, or a stone larger than 10 millimeters. Because let's be real, a rock that big is highly unlikely to pass on its own.
Finally, let's wrap things up with Section 5, Procedures and Future Prevention. Removal and next steps. We've stabilized the patient, but how do we physically get the stone out? And more importantly, how do we stop it from coming back?
Let's see how our treatment options naturally escalate based on the stone's size and location. For stones under 5 millimeters, we stick to conservative management, hydration, NSAIDs, and an alpha blocker called tamsulosin, which relaxes the distal ureter to help things pass. If that doesn't work, or if it's a bigger stone, we escalate. Extracorporeal shockwave lithotripsy, or ESWL, is fantastic for small upper tract stones. Ureteroscopy with laser fragmentation is your go-to for mid to distal ureter stones. And for those massive stones, larger than 2 centimeters or huge staghorn calculi, we bring out the big guns, percutaneous nephrolithotomy, or PCNL.
Once the stone is finally gone, prevention is the name of the game. High fluid intake is universally important for everyone to prevent dehydration, since that's the most common overall risk factor. But beyond that, prevention is super tailored. For calcium oxalate, we use thiazide diuretics. For uric acid, we want to alkalinize the urine with potassium citrate and give allopurinol. For struvite, you have to completely remove the stone and aggressively prevent future UTIs. And for cysteine, massive fluid intake and thiol drugs.
To cap off this explainer, I'm going to leave you with a classic, high-stakes scenario to test your reflexes. Imagine a patient presents with a solitary kidney, a high fever, and severe colicky flank pain. You know it's a stone, but you also know what those red flags mean. So I'll ask you, what is your immediate next step to save this patient's kidney? Keep that urologic emergency checklist firmly in mind, trust your knowledge, and I'll see you in the next explainer.